Good afternoon. Welcome to the Mid-Atlantic and Northeast Region Community of Practice Professional Training event, where we focus on preventing suicide among military and veterans. This training is presented by Serving Together, a program of Every Mind, as part of the regional community of practice efforts for the AmericaServes Mid-Atlantic region. This project was supported under a grant awarded by the Walmart Foundation to Syracuse University. This event is going to be recorded and will be shared via YouTube link once the event has ended. We will share presenter materials following the event. Please utilize the chat to communicate with participants and panelists. And if you have any questions, you can also utilize the Q&A function. This regional community of practice is available for 2 CE continuing education credits, and all certificates will be emailed to those who have registered and requested credits after the event. As you may be familiar, Every Mind is a nonprofit organization out of Montgomery County, Maryland, whose mission is to strengthen communities and empower individuals to reach optimal mental wellness. We provide a variety of direct services for the entire lifespan, including 24/7 hotline, homeless outreach, school-based mental health services, and much more. We also strive to reduce the stigma surrounding mental illness and increase the importance of mental wellness for everyone. For more information, visit our website at every-mind.org. One of our programs, Serving Together, is focused on providing resources and assistance for military veterans and their families in the National Capital Region. And among our objectives, we strive to provide education to the community to better support service members, veterans, and their families, and caregivers. Serving Together in Every Mind, we're selected to serve as the regional community of practice champion to support the work in the Mid-Atlantic and Northeast regions AmericaServes coordination centers. And the goal to provide educational training opportunities to our network users, from Serving Together in the National Capital Region, to Mission United down in South Hampton Roads, to PA-Serves in Greater Pittsburgh, to Rhode Island, or to our I-Serves in Rhode Island, and to NYC Vets, Vet Connect NYC in New York City. We conduct these trainings based on feedback that we receive from you, and we have more events lined up. So it's crucial that you provide us feedback so that we can make the most requested topics available to you. We will have a survey at the end of this training today requesting your feedback. And so we encourage everyone to provide feedback so we know how the event was today, but also what future information you'd like to receive. We will be covering the topic of suicide today. So most likely suicide has touched your communities, your neighborhoods, or your workplace. This presentation may evoke strong or distressing feelings and emotions. Please know that you can choose to leave the presentation. If you find yourself having a reaction to any of this content now or while we're discussing it today, we encourage you to please take care of yourself. We have provided the National Suicide Prevention Lifeline, along with the Veterans Crisis Line and the Vets for Warriors call lines on this slide. The National Suicide Prevention Line is available to anyone 24/7, 365 days a year. It's a free and confidential support for people in distress. If you are a veteran, military member, family, or caregiver, you can press 1 and be connected to the Veterans Crisis Line. Trained respondents can help with connection to prevention and crisis resources and support you or your loved ones, including support professionals assisting our military and veteran community. There are also chat and text options available. Another great option to speak to is someone at the Vets for Warriors line. They provide sustained confidential peer support to any veteran service member, family member, or caregiver whenever they have an issue and wherever they are in the world. And with that, it is my honor and privilege to introduce you to our keynote presenter this afternoon. Kristofer Goldsmith is the founder and president of High Ground Veterans Advocacy, a not-for-profit which partners with military and veteran service organizations to train veterans to become grassroots advocates and leaders in their local communities. High Ground Veterans Advocacy was recognized in 2016 by Hill Vets as one of the nation's top new veteran organizations. Chris was born in New York and joined the Army to serve as a forward observer with the Army's 3rd Infantry Division. Shortly after September 11th of 2001 terrorist attacks, he deployed with the Alpha Company of the 3rd Battalion, 15th Infantry Regiment in support of Operation Iraqi Freedom in the year of 2005. And since separating from the Army with a general discharge after surviving a PTSD-related suicide attempt, Chris has become an advocate for veterans with PTSD and those with less than honorable discharges. 12 years after his separation from the military, the Army corrected his discharge characterization to honorable. And as a disabled student veteran using the VA's vocational rehabilitation program, Chris found an opportunity both to recover from PTSD and to continue serving with his fellow veterans. And with that, I want to welcome Chris and thank you for joining us today.
Thank you. Thanks for having me. So first, I want to start off by thanking Serving Together and Every Mind for putting this together, and especially Christy and Janae for reaching out to me and inviting me to participate today. Before we get started, I kind of want to lead you into where we're going. The way that I think of my experience with post-traumatic stress disorder as kind of an injury and recovery is similar to road rash. Imagine you're riding on a motorcycle and fall off, and you've hit the pavement. When you get to the hospital, assuming you're not, in critical condition, one of the first memories that you're probably going to have is some nurse is going to come over and they are going to clean your wound. And while it's fresh, it's going to be extremely painful. It's going to be traumatic in itself. And then, they're going to clean it up. They're going to bandage it, come back the next day. They're going to soak it down, get it wet. They're going to scrub it with a hard brush again. It's going to really hurt. It's going to be, that in itself is going to be another terrible experience. But after a week, after 10 days or so, that horrific wound that had pieces of asphalt stuck in it is going to be clean. It's not going to be festering. And years later, you're going to be rubbing vitamin E on it, helping that scar fade. So my experience, not just with war and post-traumatic stress disorder, but talking about it has been like that, dealing with road rash kind of thing. And at this point in my life, as rough as it may sound when I describe what I've been through, it's really just rubbing vitamin E on it. So I want you to know that I am okay. And if at any point, like Christy said during this presentation, if you feel like it's too much, feel free to walk away from your screen, leave the conference and come back in later. I can promise you I will be gone after 2 o'clock Eastern. So if you don't want to see any more of me, you can come back then. So you've already got an idea of who I am today. My story starts like a lot of veterans. It's when we're kids. I wanted nothing more than to be a person in uniform my entire life. I feel like a lot of little boys grow up and little girls grow up idolizing people in uniform. That can be a doctor wearing a white lab coat, or it can be a firefighter, or it can be, in my case, an army man. If you were to look through a childhood album of me, you're going to see me wearing camouflage or having dog tags in most of my photos. It's a childhood dream for me that I never grew out of. It's the only life that I ever envisioned for myself was serving in the military. When I was 16 years old, that childhood dream started to take on a different flavor. I was 16 when the attacks of September 11th happened. I was a New Yorker living in Long Island, and it felt like every single person that I knew had been personally touched by that attack. While I myself didn't lose anyone, any of my friends or family, it felt like everyone that I was connected to, my friends at school, my aunt who was working in the city, my friends' parents who, were down by Wall Street when it happened. So not only was there this drive to serve and be in uniform and help people, but there was also an anger. There was a desire for revenge against the people who had killed innocent Americans on that day. And I feel like, for a lot of folks of my generation, they came in with a lot of the same thoughts. There was an aspect of anger and vengeance that drove us not just to want to serve, but to go out and hurt the bad guys. So at 18, shortly after I graduated from high school in 2003, I signed up for the Army. And by January of 2004, I was in basic training at Fort Sill, Oklahoma. There, I trained to be a forward observer. And I got into a job where I knew exactly what I was going to be doing. It's traditionally, whether it's Vietnam or World War II, the forward observer is the guy that you see in the movies who, when the infantrymen are walking through a valley or they're walking through a jungle or something, and they take incoming fire, everybody hits the ground, and then there's this nerdy guy with the glasses who gets onto the radio and starts shouting into it, and then shortly after that, things start blowing up. So I was the nerdy guy with the glasses. It was my job to blow stuff up if the infantry got in trouble. And I think there's no better job, for a young testosterone-filled 18-year-old kid to train for. It was a lot of fun. Basic training was a fantastic experience. I made a lot of close friends that I stuck with for a lifetime there. And then shortly after graduation, I ended up at Fort Stewart, Georgia. Now, this was 2004. It was going on 2 years into the war in Afghanistan. It was a year after the war in Iraq had started. So when I got to Fort Stewart, Georgia, I was entering a unit that had just come home from the invasion of Iraq. Now, the mindset that they had was similar to the mindset that I joined the Army with, which was like, go over there and fight. As we know from the following, 18 years, that has not really been the mission. It's not go out, there's clearly marked bad guys, you engage them, or in the, thinking of this in human terms, you kill other people. That wasn't the mission that I would be on. So I deployed a year after I went to basic training. So January of 2005, I was headed to Iraq. In Iraq, my unit ended up going to Sadr City, Baghdad. It's a slum. It is an area that has been under immense pressure with lots of sectarian violence long before Americans came in during the new Iraq War. Sadr City, before we got there, was named Saddam City. Saddam Hussein had named it after himself to make it a target so that during the Iraq-Iran war, Iranians looking at a map would say, oh, okay, he named this part of the city after himself, so he must love it. So they would bomb them. That was a way for Saddam Hussein, a Sunni, to have the pressure put on the Shia majority who inhabited that area. So by the time that I had gotten there at 19 years old, this entire area, the millions of people who lived in it, had known nothing but really warfare for at least as long as I had been alive. And my job over there, as a forward observer, was something that simply just couldn't be done. The job that I was trained for, you can't do in a densely packed city, because any time that you're calling for fire, making a mortar or an artillery round fall out of the sky, you've got a greater chance, much too high of a chance of killing innocent people. So they kind of made up this this new job on the fly for me. And I became this unofficial on the ground intelligence reporter. So I went out with my infantry platoon every single day. And in addition to my rifle and the 270 rounds of ammunition and my grenades, I also had a GPS, a notepad, pen, and a camera. And it was my job basically to be the photo documentarian, almost like a journalist who would be with the platoon every day. And at the end of every mission, I would write down what we had accomplished, what we had seen, and pass it up to the Pentagon, I guess. And now, most days, like a lot of people who've deployed, we're just boring. It's just a lot of waiting for something to happen. Most of my job doing that photo documentarian stuff was photographing sewage running through the streets and trash filled streets, and recording power outages, and interacting with local leaders, Iraqi police, to talk about how they weren't getting the support that they needed and how we might be able to help them secure their country. But sometimes it wasn't boring. There were days where things got interesting. One was actually on my way up there. I was on in a Bradley, which is an armored vehicle. It's a personnel carrier, so it's meant to bring a squad or a team of infantrymen in an armored vehicle, and basically you drop a ramp down and they come running out, and if they need to raid a building, they do that, or set up a perimeter, etc. Well, those are really expensive to get from Kuwait up to Baghdad. So instead of having this big tracked vehicle burning tons of gas and breaking down over a couple hundred miles, they strapped them onto the back of basically 18-wheelers. So instead of having a bunch of infantrymen in the back, those infantrymen flew over, taking airplanes and then helicopters to get to Sadr City, Baghdad. I was with the driver and the gunner for that vehicle, strapped. So it's, I don't know, 80,000 pounds or so, strapped to the back of an 18-wheeler, which is driven by a third country national, who's, I don't know what country they were from, maybe the Philippines. I don't know what language they spoke. We didn't have a radio to them anyway, so it wouldn't have mattered even if we could communicate. And for a couple of days, we were just driving up there. And at 19 years old, in 2005, it wasn't an iPhone era. I had little disposable cameras, and I was taking pictures of the first camels that I saw, mud huts on the side of the road, the farms. I mean, everything was new to me. Everything was exciting. I had never been outside of the Western Hemisphere before. Looking at everything, the road signs, the children on the side of the road, everything was new and exciting to me. And everything along that road after a year and a half, 2 years of war, was pockmarked with bullets and burn marks from explosions and from fires. It was very clear that this was a main road where there was a lot of action, not just during the invasion, but as convoys are going through day by day to bring in new troops, to bring in equipment and supplies. And on the second day or so, I remember seeing a road sign, very same thing that we have here in the States, the green big highway signs with a reflective white or silver lettering. And it said something like 50 kilometers to Baghdad. And I remember, seeing that, and it's kind of goofy, but I was like, oh my God, it's the first thing that I haven't seen that's like got bullet holes in it and burnt up. So I closed the hatch above my head, which is just kind of muscle memory. You're trained to close the hatch so that you're encased in this armor. And I turned to Sergeant Wright, who's to my left, and I said, hey, Sergeant Wright, something you guys didn't blow up last time. he wasn't very entertained, and he was, kind of sleeping. So he just, patted me aside. And right in that moment, the road sign that we had gone under exploded just above my vehicle. Now, I was in an armored vehicle. The explosion happened just above us. It wasn't that tremendous. It wasn't like I was knocked unconscious or anything dramatic like that. But the 18-wheelers that our vehicles were strapped to were not armored. And the vehicle behind me was the forward observer team for Bravo Company. I was in Alpha Company. So these are my friends. They're the guys who I've been training with for my, half a year at being at Fort Stewart, Georgia. And I'm listening after this explosion to these guys screaming. And all I've got are these like hard reflective periscope type windows, like these little brick sized windows, where I'm looking around and trying to figure out what's going on. And Sergeant Wright, who is actually the gunner for the vehicle, we needed to switch seats. So he hopped in, and now he's swiveling the turret that I'm in as we're driving. And I'm still just trying to figure out what's going on. And I've got this screaming in my ears, and it becomes apparent that the vehicle behind us, though the Bradley, the armored vehicle, was fine, the driver for the 18-wheeler had been injured by the explosion. Some shrapnel had gone through the windshield and hit him. And what was the driver's impulse? It was to slam on the gas and just start rocketing down the highway. Now, our convoy was tremendous. I mean, we were a division-sized element moving up into Baghdad, or maybe a brigade-sized element. So we're talking about dozens or scores of armored vehicles. And we're being escorted by military police from another unit whose job it was specifically to maintain this pipeline of equipment and troops. So my friends are freaking out because they're not just, out of control of their physical, what direction they're even moving in. They don't have any communication with the driver. The driver is clearly freaking out, and they're in a vehicle that if it rolls over, the chances of injury or death are extremely high. So that was before I even got to Fort Stewart, before I got to Sadr City, Baghdad. And, I in that moment went from the kid who was kind of carelessly hanging out of the top of this armored turret, clearly in view of anyone who might want to hurt me, to a person who, stayed clamshelled, stayed in the armor. So I'd close the top, so I'd only have this much exposed. I had realized that, the trigger person behind that bomb was trying to kill me. And the only reason that I survived is because I thought it was funny that I saw a sign that didn't have bullet holes in it yet. So that is kind of the mindset that I was stuck with for my year-long deployment to Iraq. Now, again, most of it's boring. I'm taking pictures of sewage and trash and just writing reports every day. But other times, we'd be called in to assist the Iraqi police if they found dead bodies. There was a lot of sectarian violence between the Shias and the Sunni. A lot of intertribal violence that stems from decades or even hundreds of years between tribes. And without a real functioning police force, there was, really no way to stop what was happening. We were in control of a city that had somewhere between 2 and 3 million people in it. And there was no way that, we could have protected them all the time. So one particular day, May 15th of 2005, we got called up to respond to a body being found in a trash dump just outside of the city. And by the time that we got there, it wasn't just a body, it was a mass grave. There were over a dozen human beings who were literally being pulled from the ground when we arrived. And at 19 years old, it was my job to document this experience. Now, one of the things that I had to do was take close-up photos of these faces, and ostensibly so that I could write a report, include these faces, so that they could get passed up the chain of intelligence, and hopefully, we'd figure out who they are and maybe why they were killed, and go out and get the bad guys and find justice for them. But in reality, all of that was a fruitless effort. And in the moment, it's pretty close to the summer solstice. The sun is about as hot as it gets in Iraq. It's, the average day is somewhere above 110 degrees. When it drops down to 90, 95, you're wearing a fleece because the day is so hot that even 90 to 95 degrees just feels like it's freezing. It's so hot that you can't touch your M4, your rifle, with bare hands. You need to wear gloves or you'll burn yourself, because all it takes is a couple of minutes in the sun for it to just be scalding hot. And we're in a trash dump that's also the lowest area around the city. So that's also where all the sewage is flowing. Our armored vehicles, our tanks, are over 2.5, 3 years at that point, had ripped up the city streets, had destroyed the clean water lines, mixed them, exposed the sewage lines. And all of that, instead of going through a sewage treatment system, just goes wherever gravity takes it. So that's where we are. We're in a trash dump, surrounded by sewage, digging up dead bodies. And to my left, I see a donkey that had been dumped there, a carcass that was rotting. I could see the maggots under the skin. I could see the flies landing on it. And I'm armored and covered head to toe. And the heat is just absolutely relentless. And there are flies that are landing on this donkey, that are landing on the corpses of human beings who weren't just murdered, but showed very clear signs of torture. Those flies are landing on all of that and then landing on my face. And in the moment, I'm trying to protect myself. And this is something that I kind of figured out through therapy. In the moment, I'm holding this early generation digital camera with this little 1.5, 2-inch screen on the back. And rather than look directly at the bodies and the faces of these victims, I'm only looking at the screen on the back of the camera, and I'm holding it out in front of me. And I'm basically trying to shield myself from reality in a physical way. But as I'm taking these photos, the image of the face would freeze on the back of the camera for 2 or 3 seconds. And every time that happened, that image and every detail of it just burned into my mind. So that day is something that haunted me in ways that it took me years to figure out. I ended up coming home in December of 2005 after experiencing nothing quite that bad, but other terrible experiences. And right away, my friends and family from back home knew that something was different. And at that point, post-traumatic stress disorder was not part of the American lexicon. PTSD was just an acronym to me. I literally didn't know what it stood for. And all of the guys that I deployed with, and I keep using the word guys because I was in a time when it was only guys in the unit. The guys that I deployed with had all been through the same thing. And they also had limited knowledge about the effects of war and of trauma. And when I came home, one of the first experiences that I had when I got back to New York was being at a party with friends that I had from high school for New Year's Eve. And I remember being outside, and in this moment, it's midnight. the next door neighbor sets off fireworks. And I remember, now was very intoxicated, but I clearly remember thinking, I'm home, I'm safe. This isn't gunfire. This isn't IEDs. I see that this is fireworks, and I love fireworks, but I couldn't stop myself from completely freaking out. And the person that I was with was holding on to my arm as I tried to run away. And I ended up spending, I don't know how long, but part of that night literally hiding in the bushes. But at the same time, being fully conscious of the fact that I am safe, that I am home, these are fireworks. I'm acting in a way physically that I cannot understand in the moment. So I struggled to get healthcare from the Army. Whether you have PTSD or a broken ankle, in the unit that I was in, if you were injured, if you were no good for the mission, then you were a burden and you were treated like one. So when I sought help, I was trying to do it quietly. I was trying not to let anybody know what I was going through, or that I even needed help. And I went through about a year of that, where I was just hiding my symptoms. And despite everything that I was going through, it didn't show while I was in uniform. It was during the workday, when I had my uniform on, when I was at work, I was performing ahead of my peers. I was promoted to sergeant in just over 2 years in my unit. I had a stellar career. It was when I went home that it was so evident that I was really suffering. I was sometimes on a nightly basis, just drinking straight vodka out of a plastic bottle until I passed out. And again, with the benefit of therapy and hindsight, I figured out that one of the things that I was trying to do with my self-medication was to burn the experience, the memory, the smell of that day, May 15th, 2005, with the victims of torture, with the dead donkey, with the sewage, with the trash. I was trying to burn it out of my sinuses, burn it out of my chest. And without having access to therapy, I couldn't process it. So I just kept doing it over and over again. And though my career was going well, my personal life was a mess. I was no longer communicating with my friends. My circle became extremely small. It was pretty much just people who I had deployed with, who had gone through the same things as me. I started to feel angry and resent people who had not served in the military, who had not experienced the things that I did. And I was really just consumed by anger. Now, this came to a head after January 2007, when I had been looking at my end of my contract in May of 2007 as kind of that light at the tunnel that was keeping me standing up. President Bush at the time announced the troop surge into Iraq, which meant that my unit would receive stop loss orders, which is a way of saying that I would be drafted in a backdoor kind of way into staying in the military beyond what my original active duty contract had said. And that rather than getting out of the Army and going and living the life that I saw my friends living back home, going to college and having these fun experiences, I would be playing a role in what I knew was going to be one of the most violent periods of the war up to that point. And a few days later, I experienced my first panic attack. Now, I used to pride myself in being like one of the fastest runners in my unit. And we do these things called release runs, where we'd run out like 2 or 3 miles, and then as a unit in formation, like you see in the movies, singing cadence, and then we'd get to that faraway point, and they'd release you, and as fast as you could make it back to your barracks or your car, you could leave, and then come back at 9 o'clock for the rest of the workday. So I ran home, back to the company area, and I just remember after my run, it's, usually after 30 seconds, a minute, my heart rate starts to slow down. I, start to feel cooler, but it's not stopping. It feels, I'm resting, sitting down, but I feel like I'm sprinting. My heart rate, my breathing rate is just out of control. And at that point, I didn't know what a panic attack was. So I thought I was dying. I ended up going to the hospital. And at that point, it was the first time after getting an EKG and being told if physically you're fine, a physician's assistant in the Army asks me, do you think you might be stressed out? And I basically gave him what I've given you so far. And I was like, yeah, of course I'm stressed out. 4 months from now, I was planning on getting out of the Army. And here I am, 4 months from now, I'm about to be sent on what looks like could be a 16 to 18 month deployment. And it would have been great if at that point the Army had recognized my illness, my post-traumatic stress disorder. But the Army didn't diagnose me with PTSD. Instead, they diagnosed me with adjustment disorder, which I'm sure a bunch of you are familiar with, is similar signs and symptoms of PTSD, but PTSD is long lasting, whereas adjustment disorder is adjusting to a certain change in your life. And the night before I was set to deploy for what would have been my second deployment, I attempted suicide. I took my same usual poison of vodka, along with a handful of Percocet that I had had from a recent surgery, and I attempted to take my own life. That was the last expression of control of my own fate that I felt that I had. And from the moment that I woke up handcuffed to a gurney in the hospital, I went from being treated as kind of the golden boy in my unit to being treated like a criminal. And within 3 months, I was kicked out of the Army, received a general discharge, or what I call a bad paper discharge. And I went from Sergeant Goldsmith, well-respected, well-liked, to Chris Goldsmith living in his childhood bedroom in his mom's house. And thus began a 5-year dark period of my life that honestly I don't remember most of, because I was pretty drunk the whole time. But I did have one thing that was critical. I did have access to VA healthcare, and it took a long time. And I got to say that I wasn't the best patient all the time. But for about 5 years, I was going into the VA sometimes as often as on a weekly basis, and I had a fantastic team who was taking care of me, who were in the OIF, OEF, our unit for Iraq and Afghanistan veterans, and they knew maybe not what I had been through, but they knew how to help, and that saved my life. That is where I got to learn about how telling my story, as I've just told you, is as terrible as the things that I went through were, and how painful it was to really relive those experiences as I was speaking them aloud. I learned that, like road rash and like that tough nurse who comes over with the hard bristle brush to scrape out your wounds, it gets better over time. The therapy itself may feel re-traumatizing, may feel terrible, but over time I learned that not only would I survive, but I would find a reason to live. One of the things that I lost with my general discharge, as opposed to having an honorable discharge, is my eligibility for the GI Bill. And that's one of the things that not having an economic opportunity that other veterans had, so I could learn a new skill, so that I could go to school, and coming out into an economy that was collapsing in 2007, 2008, severely limited my my ability to heal mentally and emotionally. But after about 5 years, I found out I was eligible for a program called vocational rehabilitation, where they take veterans who have a service-connected disability, and they help them find a new way to earn a living. And thankfully, I landed in school. Other opportunities could have been, they could have sent me to a trade school or something like that. I started off at my community college, and there I finally started to reintegrate back into greater society. Prior to that, the only way that I was socializing was in a bar, getting drunk. And I went from never having been a good student to really caring about my grades, and starting off, with a strong 4.0. And within my first semester, I went from being the kind of stereotypical vet, wearing a hoodie, sitting, in the back corner, quietly doing his homework, to being elected as my Student Veterans America's, the school's chapter, as president. And there I represented 250 veterans. So I had finally found a leadership position. I had finally found a community that was welcoming, that was gave me a mission again. And through that's when I first started telling my story publicly, outside of just in a clinical setting, or in a setting where I'm speaking out against the Iraq War at the time, because I was very anti-war. And I was lucky to have found a mentor finally, someone who could help me direct the anger, the anguish that I was experiencing in a positive way. And I, thanks to my community college, started learning how to do research, started learning how to write a policy paper. And my mentor at the time had spent time on Capitol Hill, and he, somewhat like a dad joke kind of thing, had a habit of saying, that's outrageous, there ought to be a law. And well, good thing I used to work on Capitol Hill, so I know exactly how to do that. And the guy's name is Chuck, and Chuck taught me how to become an effective advocate, how to communicate my story in a way that would motivate positive change, motivate lawmakers, motivate their lawmakers' staff to get invested in not just hearing a problem like the trauma that I had gone through, but hearing solutions. So in my case, it was solutions on how to help veterans with bad paper discharges get upgrades so that they could become eligible for things like the GI Bill, for things like veterans VA healthcare that veterans with other than honorable or OTH discharges have historically been eliminated from. And through that, I found my passion. I started off at my community college wanting to be an engineer, kind of chasing dollar signs. And it was in the extracurriculars, through my student veterans club, through my mentor, Chuck, that I figured out, I really wanted nothing more in life than to serve. And maybe serving in uniform didn't work out, but there are other ways that I could serve my community. So since then, I returned to Washington, D.C. on a yearly basis, every year, trying to propose laws and amendments to laws that would help veterans with bad paper discharges get a more fair shake, so that they'd be able to appeal their discharges, so that they'd be able to get access to those critical benefits that allow them to heal the same way that the VA helped me heal. And that's what I based my nonprofit on. High Ground Veterans Advocacy takes those lessons that I learned over the years in telling my story in a way that feels therapeutic to me, but also makes an emotional connection with people, and alongside that, propose solutions to problems. And since since we were created in the beginning of 2016, we've trained over a dozen fellows, each on their own issue that is driven by their own personal experiences, by their own passions. And we've trained them to become effective advocates in advocating for change, not just at the federal level, but back home. It has been a tremendous honor, to be able to serve my country in this way. And one of the things that I'm so happy that I've been able to do is find out that I could take this horrible experience, the trauma of war, the years of depression and anxiety, of post-traumatic stress disorder, and I could turn it into a weapon. I could wield my anger, I could wield my anguish in a positive way. And rather than be self-destructive, drinking myself into a black hole, I would, take the pain that I felt pressing on my chest every day and hand it to other people and say, you can help me by making sure that my experiences aren't shared by future generations of vets, so that other vets are not going through the things that I have. So I guess the moral of the story here is that a lot of times it's extremely difficult, and it feels hopeless. And in a case like mine, you may feel for years, individual patients, veterans may feel for years like there's just no progress. And then they find that one thing. For me, it was finding a mentor who could translate my trauma into positive change, who could help me figure out a way to serve my country in another capacity. And that's not just what saved my life, but what gave me a reason to live. And again, I want to thank all of you for your attendance today, for getting involved in careers that are bringing you here, because your service is absolutely critical. You are a force multiplier. The VA can't do it alone. No one organization can do it alone, but all of you are helping to make sure that stories like mine have happy endings. So with that, I'd like to open it up for questions if anybody has any. All right, Chris, are you gonna be a moderator for this?
Yes, sorry, I had to run and grab my dog while she was barking.
Oh, it's okay.
Sorry about that, and thank you, Chris, so much. This was such an amazing, way to help other individuals understand the challenges, when it comes to our military and veterans. We do have a few questions that have come through, so I'm going to ask the first one. It says, "Dear Mr. Goldsmith, thank you for speaking to us. I weep for your experience. I can't imagine what it was like. I heard a former veteran say that thank you for your service is not an appropriate way to say." So what does one say to a veteran or those that are serving?
It took me a long time to figure out how I could respond to people saying thank you for your service. After the trauma that I had been through, I didn't have any feeling like, I guess, growing up, all of the vets that I knew as when I was a little kid were World War II vets. They beat fascism. They saved the world, saved democracy. I came home to a war that continued for another 15 years and is still going on today. So thank you to your service. When I was in my most raw state, felt painful. And I don't think that it's necessarily up to the people who want to thank veterans for their service to figure it out. I think it's up to people like me, the veterans themselves, to figure out how to respond to that. And it took me years to get to this, but just thinking, well, thank you for your support. That's because at other points I wanted to say, my service didn't do anything. There's no reason for you to thank me. The world's not a safer place because I went to Iraq and took photos of dead bodies, right? That's the kind of angry response that that first came to me. But thank you for your service may feel triggering for some vets, but I don't think that there's any better short greeting that you can give. It's what you really mean when you say thank for your service is thank you for your sacrifice, thank you for your intentions. And I don't know if the instances that you might have in your mind are short and long enough for you to kind of explain that, but trying to get across that that's what you're really thankful for is thank you for trying to make the world a better place. That I think is something that more vets who may be uncomfortable with their service may feel more comfortable about.
Thank you, Chris. So we have lots of questions and comments coming through. So if you guys can, please move your questions to the Q&A so I can see them more easily. And we'll just do a few more questions before we need to wrap up to our breakout sessions. But we had someone ask, and maybe you know this or maybe you don't, just from your experience working with other veterans that have come out more recently in the past few years, but how is PTSD or PTS seen today in the military?
So my understanding, and I've been out for a long time now, for 13 years, and that is like a generation and a half, or maybe 2 or 3. I don't know. Like the generations of folks who've deployed to Iraq and Afghanistan since that have gone through very, very different experiences from what I have. My understanding from talking to the most recent veterans is that there still is this stigma in a lot of places. There are more services available. There are more confidential services available. But the stigma of feeling like if you are perceived as broken or injured or wounded, that you're going to get treated differently, that still exists. And if I could snap my fingers and change one thing about the military, it would be bringing an end to that. And the only way that I think that there can be an end to that is accountability for senior leadership. They are the ones who set the tone for the entire unit. And if the youngest private in any unit is not comfortable asking for help, that's a failure of every single person who outranks them.
Thank you, Chris. I've got lots of questions in here, so I'm going to try and hit a few of these. We had an individual ask, why would the military want to keep people who are suicidal off the GI Bill? Is there a way that the act of suicide or attempting suicide can be reclassified in terms of the flow chart that leads the person to receive less than honorable discharge? And I don't know if you have any experience answering that, but we'd love your thoughts.
Sure. So the repercussions that come with a bad paper discharge is not something that the individuals who are responsible for issuing that, what is a lifetime punishment in most cases, there's not a feedback loop. The captain who signed the paperwork, the staff sergeant who initiated proceedings against me, they don't have to know or care whatever happens to me in the future. Their priority is in the moment. And what they are responsible for is the numbers on the books, those numbers being human beings. And if you have a great number of human beings who need rehabilitation, whether that be for misconduct or for injuries or illnesses, those are people who can't participate in the mission, who are dragging your numbers down. And the shortest and easiest way to get rid of someone is to kick them out with bad paper. The denial of things like the GI Bill and the healthcare benefits is not something that matters to the people who are imposing, again, what is essentially a lifetime punishment. It's really just about their own responsibility to prepare people to go to war.
Thank you. I'm going to do one more. We do have several more on here. So if you're open to it, we can send you these list of questions and kind of get your response or any of your thoughts, and we can then email them out after the event.
Sure, yeah, that'd be great.
Thank you, Chris. So there is a question in here that said, I very much appreciate listening to you today. You're an effective advocate for change. What did you identify as the motivation for you to make the change when you hit your lowest points?
So my lowest points were not isolated to just when I first got out. You know, post-traumatic stress disorder is something that sometimes you have under control and sometimes you don't. And for me, personally, so this is not a prescription that fits everyone. The thing that kept me alive at my lowest points was spite. I wanted to be as spiteful as I could for those who had, been a part of ending my Army career the way that they wanted to, and people who who I felt didn't want to see me succeed in school, for example. For me, the most powerful emotion to drive me to want to move forward was anger. Now, that is not necessarily a good thing, but I learned how to make do with what I had. And, I'm not going to recommend that people try and, be angry to get better, but that's what worked for me.
Thank you, Chris. And I hope that you get a chance to read some of the chat comments that have come through. Just so inspiring story to know that you are now helping other veterans. You're sharing your story, and you're really also helping the many hundreds of organizations that are out there that better want to understand how they can better serve the military and veteran space. So you sharing your story today has been, just seeing the comments, how wonderful it is for them to better understand that insight. So thank you again for joining us today. And thank you again for sharing your story and inspiring others now with the work that you're doing with High Ground Veteran Advocacy.
Thank you. And again, I want to thank everybody who's tuning in today for your service to your country and to this community. Veterans may not always be good at saying thank you for your service. So I just want to say it on behalf of my sisters and brothers. Thank you for your service.
Thank you. All right. And so with that, we are going to move into our breakout sessions. So we have 3 breakout sessions available for you all today, including a presentation by Hampton VA Medical Center's Megan Flaherty that will discuss lethal means when it comes to suicide prevention efforts. We'll also have a presentation by Headstrong, who will be a conversation from retired Colonel, U.S. Army Colonel Jim McDonough and Miguel Osegunda. And they're going to be talking about preventing suicide, a clinical approach. And then the third panel discussion and breakout session is actually going to stay right here in this webinar. So it's going to be a discussion moderated by Brandy Jankaitis about the community impact of suicide prevention. And we're excited to have a robust panel joined by Dr. Sharonda Farrow, Adam Chu, and Greg Roos. So we encourage you, if you which breakout session that you would like to go to, you're welcome to stay in this one, or go ahead and move now to either the lethal means breakout session or the clinical approach breakout session. And the links will be shared in the chat. If you didn't get them via email, they are available for you to click right there into the chat to move into that, to the other session. We'll give you guys just a minute to go ahead and move forward into your designated breakout sessions. We had a question that asks if all the sessions will be recorded and available later. Yes, they are all going to be recorded, and we will be posting them all on YouTube for you to be able to see anyone that you want to after this event. All right, and with that, we'll be getting ready to move over to our community panel on the community impact of suicide prevention for those that will be staying in this room. So I have the pleasure of getting to introduce you to another wonderful individual in this space. So again, thank you all for joining the Community Impact Suicide Prevention Breakout Session. We are excited to introduce you to our moderator and panelist, Brandy Jankaitis. Brandy brings an extensive personal and professional experience in programs and services for military and veteran families. She currently serves as the director of the Virginia Veteran and Family Support Program at the Virginia Department of Veteran Services. VVFS is a statewide program that provides peer and family support and behavioral services and supportive services linkages to military veterans and their families. She also leads regional and statewide suicide prevention efforts for service members, veterans, and their families in partnership with the Veterans Health Administration and Substance Abuse and Mental Health Services Administration, including Richmond Mayor's Suicide Prevention Challenge, statewide governor's Suicide Prevention Challenge teams. And she's also has served previously as the Director of Housing Development for Veterans at Virginia Department of Veteran Services and worked for the statewide effort to reach the end of functional homelessness for veteran homelessness in Virginia. At the Virginia Department of Behavioral Health and Developmental Services, Brandy served as the first Veteran and Military and Veteran Affairs Director and helped enhance treatment and supportive services for service members, veterans, and their families in the public mental health system. And so with that, I'm going to turn it over to Brandy. Thank you again for leading up this important panel conversation, and I will turn it over to you to welcome our panelists.
Thank you so much, Christy and Janae, for all of your coordination and planning to get us to this point. Thank you to all of our Serving Together partners along the East Coast. It's really a pleasure to be here with you this afternoon to talk about the importance of community involvement in suicide prevention. So I will first go through our esteemed panel bios here. You have the panelists, of course, at the top. Hi, guys. And then their pictures here on the slide. And so we'll go through bios, and then we will go to Adam first for his presentation. But first, let's learn a little bit about who's going to talk to us today. So Dr. Farrow is with us with the suicide prevention team from Hampton VA Medical Center. I'm a little biased on Dr. Farrow because she's an instrumental partner in the Governor's Challenge work and also a fellow Virginian. And she's a licensed clinical psychologist. Dr. Farrow has experience in working with a wide variety of individuals providing risk assessment, crisis intervention, outpatient mental health, psychological evaluation, and forensic services. Dr. Farrow provides consultation and training for healthcare professionals and others, to include all of us today, in the VA and outside the VA. So welcome, Dr. Farrow. Next up is Greg. Greg serves as the board chair and volunteer for the Maryland chapter of the American Foundation for Suicide Prevention. His focus areas include suicide prevention education, advocacy, and coalition building. Greg is a U.S. Marine Corps veteran and has both with service and staff roles 30 years of Marine Corps service. So Greg, we appreciate your service and sacrifice and personal connection to this mission. He then worked in the defense industry through 2016, is a graduate of the U.S. Navy Academy and Naval Postgraduate School and Salisbury University, where he earned a Master's of Social Work, and is an active community volunteer and licensed Master of Social Worker. So, you know, you bring that amazing blend of personal military experience and also clinical experience, which is just phenomenal. And then we have Adam. Mr. Chu is the Director of Health and Behavioral Health Initiatives with the Suicide Prevention Resource Center, SPRC. If SPRC is not your go-to when you're researching community suicide prevention, it will be after this presentation. Make sure you look at the SPRC closely. In Adam's position, he leads projects to build capacity to deliver effective suicide prevention services across states, communities, civilian health systems, military treatment facilities, emergency departments, primary care, inpatient and outpatient settings. Adam has provided consultation to SAMHSA Zero Suicide, Garrett Lee Smith Youth Suicide Prevention, and the National Strategy for Suicide Prevention grantees. And he's also a key partner for all of our Mayor's Challenge and Governor's Suicide Prevention Challenge efforts across the nation. He also works with the Manchester, New Hampshire VA Medical Center in the implementation of Zero Suicide. Adam has his BS from Tufts University and his Master's in Public Health from the Boston University School of Public Health. So I know you all feel like I do in that we have an incredible panel for us this afternoon. So welcome again. And with that, Adam, I'll turn it to you.
Great, thanks very much, Brandy, and thank you all for having me. I'm going to kick off the panel here and do my best to set the stage a bit and provide some context for comprehensive community suicide prevention. I'll talk through some of the key elements and how I tend to think about this, hopefully in a way that is straightforward and maybe less about the different models and frameworks, and give more of a straightforward way to think through how this applies to how you might think about suicide prevention in your local community and in the work that you do. And so when I think of comprehensive community suicide prevention, I think of something rooted in a public health approach. So I come from a public health background. This resonates well with me. And what it means is that really multiple strategies that focus both on preventing crisis and also responding to a crisis are necessary. And so you need things that are guided by data and information about suicide in your community and your locality. And also you want to collect information about what's working and information about what's going to tell you whether what you think is happening with suicide prevention in your community is actually happening. And you'll see a little bit on this data later. I think Brandy's going to touch on some of what they found as a part of their work. So the broad takeaway, I think, for what my remarks here, that community suicide prevention requires multiple components. It's not just one thing. And the research indicates this, that it can't just be one strategy, one healthcare system, one community agency, one state department, one state agency. It really is a collective effort because suicide is too complex a problem that influences individuals in too many different ways for it to be one entity's responsibility. And so if nothing else, remember that it's a multiple component approach is what makes this community suicide prevention work. All right, so I said community suicide prevention requires multiple components. What do I mean by multiple components? So it means that we need to include activities that reach people before they are at or are going to develop suicide risk. So that means things that help support individuals and care for them, support individuals and build their resilience, let's say, before they get to a point where they are in crisis. And then on the other hand, we do need activities that help support and care for individuals when they are at high risk or they are experiencing a crisis or they're interacting with a healthcare system and seeking care for something in their lives that could become a crisis. And then I think the other thing that our research tells us that sustaining these activities is essential. There's been some studies showing that when you do work in counties, and this was related to youth population, you can have an impact on both suicide rate and attempts, and that effect tails off if you don't sustain some of the activities that are going on. And so because there are many components, and because you need to be looking out for individuals before the risk for suicide develops or before they're in a crisis, and during and afterwards, it is a really big ask. And so that's also another reason why not one entity can do everything on its own. Not one entity can take on every strategy that could be a part of a comprehensive approach. So that means to be effective, suicide prevention activity needs to involve many organizations. And I think this is acknowledged in VA's national strategy to prevent veteran suicide very well, and that really calls on community agencies to play a role in preventing suicide in an equal way that the VA has a responsibility for this too. One other thing I want to say with respect to taking on the different roles and activities that would be a part of comprehensive community-based suicide prevention, it's that although there are many organizations involved and there are many potential activities that you could do, one other strand in this is that your activities that you plan, no matter what organization is leading the particular suicide prevention work, they can't just be something that focuses on individuals. They can't just be activities that focus on the community. And they also can't just be policy level initiatives. So there is a bit of there's several different levels within a community that need to be addressed as a part of your overarching suicide prevention approach. And so, you might take some action that influences individuals, like maybe there's some resilience building that is done, or you're coaching people on how to negotiate social conflicts, or maybe they need help with navigating housing instability, these things that will help people before they have a crisis, right? Maybe it focuses on the individual there. At a social or community level, maybe you want to do something to promote connectedness within the community. And that doesn't just mean hosting events where people can gather, although, setting aside the pandemic currently, that on its own wouldn't necessarily provide what people need. There's meaningful connection and engagement with the community that's a part of that. Or on the other hand, mobilizing community members who are likely to be interacting with folks who are at risk for suicide to know what to do when they see warning signs. So they need to learn skills to identify those and how to refer someone to appropriate care when they do need to use those skills. And at the policy level, there could be many things. I think in the last 10 years in suicide prevention, we've seen policy level interventions such as legislation requiring training for school staff in recognizing risk, training for providers in assessing and managing risk for suicide. These could be policy level interventions related to funding crisis response systems, altering the way that certain parts of suicide care and healthcare systems are financed and reimbursed. And then we've seen, continued investment in grants to both research certain components of suicide prevention and also to provide those directly to states and communities to build their own comprehensive approaches. And so I think, the three threads I spoke about here were that multiple organizations, multiple components and activities within those, and they need to impact different levels within your community. So that is kind of a round picture for how I tend to think about community-based suicide prevention. And there are several different ways that this information has been packaged for folks to reference in terms of models and frameworks. So I don't want to necessarily get bogged down in the different kinds or different models that there are, and they're all very useful and provide great guidance on how to think through comprehensive suicide prevention. But the one I think I'll touch on, because I think it falls very much in line with the information Brandon will share, and we've used it as a part of the Governors and Mayors Challenge to prevent service members, veterans, and their families suicide, is the one from the CDC. And so CDC's technical package for preventing suicide really pulls together the several levels of three strands, let's say, that I mentioned in a nice way. And I'm actually going to put it right into the chat for future reference so we have it. I know it just went to us as panelists, but I want to make a record of it so it's there. But As I said, it provides a review of different suicide prevention strategies, somewhat of a menu, and then also some options for approaches that start to kind of operationalize some of the strategies that are there. And strategies, for example, I'll just list a few. There's I think 7 of them or 9 of them in the technical package, but it includes things like strengthening access and delivery of suicide care. So clearly a role for health systems or behavioral health services, community mental health services there. Identifying and supporting people at risk. So again, this is at the level of folks who have some risk already. So it's not so much the prevent folks from becoming in a state where they're in a crisis, but more in, okay, we've identified someone at risk. And this could be in the community. It could be as a part of crisis response. It could be somebody who goes to get services from the VA, from another mental health agency. And then on the other hand, it also includes strategies like strengthening economic supports, teaching coping and problem solving skills. These much more on the end of providing individuals with skills and knowledge that help prevent them from having a personal crisis in the first place. So we have both pieces represented, as I mentioned before. For comprehensive, we have both ends of the spectrum. Just to mention another example, and there are overlaps, which I think sometimes are helpful if you can pick out the overlaps. There is also a comprehensive approach example on the Suicide Prevention Resource Center website, which I put that in for sharing out later, or I see, thank you, Brandy, for blasting that out to the group as well. Just for another flavor, I think they both provide the same kind of outlook on, engaging multiple components of a community to respond. And one last one, it's a little bit of a different resource, but it comes from the National Action Alliance for Suicide Prevention, which is a public-private partnership that is, their main goal is to advance the national strategy for suicide prevention. And they pulled together a Transforming Communities document. And I guess the best way to describe it is it kind of measures out the key ingredients you need to actually implement a comprehensive approach. So it takes you maybe one level deeper than the strategies and approaches and says, hey, across a community, here are the common threads that should be in place to actually make this work or make it more likely to work for you. So I think the action step that comes to mind just from this overview is you're thinking about a comprehensive approach for your community or a comprehensive set of strategies that will land. Think about what's your bundle. And the reason I changed the term bundle here is because for you in your organization or in your role or profession, you may only be able to influence some bundle of the approach and not the whole thing. And that's totally realistic. And the reason why you need partners and other organizations engaged. So you want to think about, if you're going to be involved in planning this work or advancing this work in some way so that you can get more folks involved, who should be involved? Which organizations are there, which aren't, that should be? What's the existing suicide prevention infrastructure in your community, at your state? Who's been driving this work historically? And so you might hear about some of the organizations that have been engaged, particularly from Brandy later on, but could be Department of Social Services, your hospitals, Hospital Association, State Department of Veterans Services, your VA facilities, community service organizations, folks, and also groups like American Foundation for Suicide Prevention. You're going to hear from Greg shortly as well. Veteran service organizations, law enforcement, first responders, housing and financial support and counseling services, those that don't feel or look like suicide prevention, but they could be suicide prevention if they prevent someone from, being in a place of crisis. You think broadly about who needs to be engaged. And I think with that, I'll pause. There's another line of work I can speak to a bit later for the Action Alliance, but I think I want to keep this thread going and allow for the other panelists to pick things up where I leave it.
Thanks, Adam.
Sure.
So what we're going to do is go ahead and flow through the presentation so that we can leave a good chunk of time at the end for dialogue. So you can throw your questions in the chat. You can write them down so we don't forget them, but we will pause at the end to come back to have some good group dialogue with our great panelists here. So Dr. Farrow, that puts you up next. And Christy or Janae, can we move the slide forward? Thank you.
Thank you. Yes, I did create a little bit of a cheat sheet because there's so much that we're doing, and I'm hoping to include as much as possible. You know, we do know that the military and veteran population are at an increased risk for suicide for a number of reasons. And so the VA continues to be a leader in suicide prevention efforts. You can go to the next one for me. So with that, you know, given that it's a national public health issue and impacts people from all walks of life, right? Regardless of whether or not they served in the military, but we also know that it's preventable. So for that reason, we do support the national goal of reducing annual suicide rates across the board and are implementing that public health approach to achieve that mission. So our strategic plan, which Adam had mentioned, does identify preventing suicide, veteran suicide, as our highest clinical priority. We do, however, know that the majority of veterans that die by suicide are not connected to the VA for a variety of reasons. And so we've been very purposeful about how we manage suicide risk. And in doing so, the VA has adopted this public health model of approach. So for that next one, our suicide prevention 2.0, it really does seek to answer, the questions of how that, the problem begins and what are our best solutions for preventing it from occurring in the first place. And because it's so complex, it does require, coordinated evidence-based solutions that reach beyond that traditional medical model of prevention. So, we really have embraced that comprehensive public health approach. Additionally, we've gotten some numbers back from our national data that shows that the suicide rates for those who are not connected to the VA are still continuing to rise, but those who are connected in some way have seen a decline. So we want to make sure that we're reaching out to those who are in the most need. So we want to do things like involving peers and family members and the entire community in our approach in reducing that rate. So the changing face of suicide prevention is really providing an entire network of resources and information for the management of high-risk veterans everywhere, not just necessarily those who are connected to our services. Okay, for the next one. I wanted to just talk a little bit about the President's Roadmap to empower veterans and end the national tragedy of suicide, or that PREVENTS model. Not to get too far into the weeds, but it is a very holistic approach and talks about how to prevent suicide across the board. And so what it does is just change that culture around mental health and suicide prevention by integrating communities, looking at research activities that will drive all of those other strategies to encourage an overall health and well-being. So that holistic public health approach is very much in line with the national strategy for suicide prevention for our veterans and military. And one of those central tenets is adopting that scientific approach. So we support ongoing research for veteran suicide prevention so that we can determine, what are the best practices? And that's going to inform those other pillars. So for example, okay, how are we going to reduce that stigma and provide education to the community? Whether it be via, marketing materials or SAVE, which is, our gatekeeper training. How do we go out, and build partnerships? What partnerships are important, to support our prevention efforts? Who should we target? What are the policies that we need to help develop? And most of all, once we've begun to do all those things, is it beneficial and is it effective? Because we want to make sure that we're focusing our energies where it's needed. So for the next one, our national strategy really encompasses 4 interconnected directions, right? We're looking at the healthy and empowered veterans, families, and communities, looking at clinical and community preventative services, treatment and support, as well as the surveillance, research, and evaluation. So the action plan gives an idea of the supportive community environments that we're promoting to reduce suicidal behaviors, the associated risks, and the barriers to care. So communication efforts will include things like our campaigns and social marketing. Those play an important role in changing the knowledge, attitudes, and behaviors that can help prevent suicide. We're using more, safe and positive messaging to address mental illness, substance abuse, and suicide so that we can reduce the stigma that's there and promote help seeking. For example, I'm sure many have seen, our Be There marketing campaigns to prevent suicide, and commercials, and on the internet, even on my phone. I've seen it in various applications. So just trying to get that education out there to anyone who would be able to help encourage a veteran to get the help that's needed. We also look at developing and promoting educational materials about the warning signs for veteran suicide and how to connect individuals in crisis with assistance and with care. So again, providing that gatekeeper training or training to different organizations about how to spot signs. Are we going out to faith-based communities or churches and talking about how to look for signs in your parishioners, right? Going to provide save within the community to family members and caregivers, that sort of thing. We promote knowledge and use of the Veterans Crisis Line, which of course is that 24-hour crisis line that anyone can use, and veterans and families can press 1, but helping to make sure that everyone knows that resource is available and how to access it. So we'll provide materials and marketing out in the community for that as well. Providing training for providers, not just VA providers, but those who are out in the community at hospitals and private practices and community service boards and other agencies about suicide prevention, military culture, and related behaviors and associated factors. But we also promote adopting core education and training guidelines on the prevention of suicide. So working with state task force and others to develop policies for professional competency to make sure that the treatment that's provided is going to help to prevent suicide in our veterans and military individuals. We provide care and support to those who are also affected by suicide deaths. So that postvention work to promote healing in the community, but also to help prevent further suicides. So we look at the development of guidelines for those support programs for individuals who might be bereaved by suicide and implementing those across all levels. For that next one, I just wanted to give an idea of some of the collaborative relationships that are there, because part of that collaboration really is to foster the integration of veteran suicide prevention across the values, the culture, and the leadership of the work of a broad range of organizations and programs. So there's a role to play for everyone in supporting suicide prevention activities. Because we know that veterans are also members of their community and actually spend, of course, the majority of their time in the community as opposed to with us in our VA facilities, we want suicide prevention to be integrated into all the activities, the organizations and programs that provide supports and services. So while we know that, all the national and state, local, regional, however many organizations can play a role, I just included some examples of those that we particularly work with in terms of our veterans. So for example, law enforcement and first responders, how to spot the signs of suicide risk, how to engage them and get them connected to the VA, how to get them connected to resources that they may need, and having a liaison and a good working relationship. So, local government associations and services boards, even going to gun shops and providing not only education, but also information about how to spot signs and how to usher our veterans into treatment and to promote use of the Veterans Crisis Line if there are difficulties, as well as the services that we offer, such as Save Within the Community. Within our facility, on the next one, we're also looking at being able to bolster our efforts to engage in best practices. So making sure that we're providing evidence-based treatments for suicide prevention, as well as for other mental health disorders, whether it be not just mental health, but I should say physical health and well-being as well, right? So across our facilities, we make sure that we are doing things that are reducing suicidal thoughts and behaviors across the board. We've adopted the understanding that suicide prevention is everyone's business. So we look at, screening, evaluation, access to care, and making sure that we're using a 3-tiered framework. So universal screening, education and information, but also providing specific interventions for both the selected and indicated populations. So we've got our risk ID process, for example, which is our screening that we do for suicide thoughts, but it's across the board for all veterans. We also have, certain areas and sites that we do additional screening for. And we also have some very indicated screening that we do as well. But we do COVID calls, right? Or we also have analytics to identify those who might be at higher risk, to make sure that those veterans who are at the most need are being outreached on a regular basis, or even identifying those groups who are at higher risk. So our homeless veterans or those who are newly transitioning, to make sure that we not only screen for suicide risk, but also provide resources to address the other risk factors that might be there. Suicide prevention team, of course, is a great resource. So we look at doing things like case consultation for those who may need assistance, managing the high-risk veterans, providing lethal means safety training and materials to enhance safety, like gun locks and pillboxes, not just within the facility, but again, to connect with the community as well. And I wanted to mention just, using technology and social media, our virtual applications. So we're using things like telehealth nursing for our high-risk veterans, or we're monitoring daily symptoms, using Video Connect for mental health and physical behavioral health, medical appointments now, especially with, the COVID that's happened, pandemic. Promoting things like Make the Connection, which is a virtual support group for veterans, or coping and symptom management applications that can be used, or using social media messages, right, to push information out to all who might benefit from those things. So we're really looking at a comprehensive and very robust approach to suicide prevention within the VA.
Thank you, Dr. Farrow. All right, so we're not going to jump right into these slides just yet. Next up is Greg with the American Foundation for Suicide Prevention. To continue on the theme of critical community partners, I definitely think of AFSP in that category. Take us away, Greg.
Well, thank you very much. And I'll apologize for my voice. This isn't karaoke. I think this is just Zoom fatigue. But my name is Greg. I'm a Marine veteran. I'm a volunteer with AFSP. I'm a lost survivor. I lost a Marine 15 years ago in between deployments. And that's what brought me to AFSP. So if you're not familiar with us, we're a national nonprofit. Our mission is to save lives and give hope to folks that have been affected by suicide. We have 75 chapters across all 50 states. And I'm going to be drinking water for self-care. And thanks to Adam and Dr. Farrow, I'll save some of my words because I think they're very complimentary in how we're approaching the challenge and the opportunity, because suicide is preventable. And I think the all hands, the multifaceted, multidisciplined approaches making progress. So the way the AFSP is organized, our efforts are really in four main areas: advocacy, research, education, and support the survivors. Advocacy is at the federal and state level to advance mental wellness and legislation for veterans and active duty military and family member suicide prevention. Also at the state level, an example of that is our bill last year signed by Governor Hogan that now has Maryland as one of the Governor Challenge participants this year. And it advocated for a comprehensive approach to veteran suicide. And I think many of our chapters are advocating in that regard, from a state capitol day to providing testimony. And we did that here in the state of Maryland, and it makes a difference. On a research, we're the largest private funder of suicide prevention research. A couple of the research areas that we've funded relative to veterans has to do with post-traumatic stress disorder, traumatic brain injury, transition from the young OIF, OEF veterans to veterans that look a little bit more like me and are a bit older. And it really looks at psychological resilience and their ability to be able to do some of those things at what might be appropriate. On education, I think what's beautiful about that is we use the research and this is absolutely a team sport. So when you talk about Action Alliance or some of the other things, we are Project 2025, where we focus on particular settings of saving folks, that be within the firearms community, healthcare systems, emergency departments, and also corrections. And as you might know, corrections, that's the leading cause of death is suicide. So when it comes to Governor Challenge Action Plan, and in particular, access to lethal means and safe storage, we've partnered with the VA and also the National Shooting Sports Foundation. And we have a toolkit actually that looks at safe storage for your community that's tailorable for all of us, where we work with our local VA state suicide prevention coordinator. We provide educational material, everything from the vet center to the community-based operational community center. And in conjunction, not only with the pill boxes and also the gun locks, we provide that education for family members, for staff, and for veterans. And we happily do that. And it's nice that we can work that together. So we have these high-level strategic partnerships, whether it be with NSSF, or SAMHSA, or the Action Alliance. But what's nice about AFSP is this brings it to your backyard. This really is a grassroots effort because we are represented in all of your communities. A couple of comments were made. We have a presentation that we offer, something called Talk Saves Lives. And it really is a 30-minute presentation, and all of us have something similar, but it addresses risk factors and warning signs, protective factors, how to have the discussion with if you're at risk or somebody else might be at risk. And I think that's powerful, and you tailor it, and we tailor it to the various audiences we have, and to include for firearms and what safe storage really means. And so that gun owners, folks at retailers, folks in the ranges have an understanding. And I think most of you are aware, half of our suicides are completed with a firearm. And for veterans, that number can be up to 70% completed with a firearm. So we feel as though we're making progress in that regard. One of the other areas that we do is provide support for suicide survivors. We have something called Healthy Conversations, where we connect folks peer-to-peer. If you've lost a family member, we'll connect you with a family member, a vet to a vet, a parent to a parent, and likewise. And that connects folks with resources at the time when they're probably most vulnerable. You talked about a number of activities that are sustainable. And this year is kind of wacky. We're all adapting, but we have Out of the Darkness community walks. This year, those were virtual. In the spring, we'll have Out of the Darkness campus walks for colleges and high schools, because as Dr. Farrow mentioned, educational institutions, I mean, veterans are in the community. They're at the community college, they're everywhere. So we find the Out of the Darkness walks, especially now doing it Zoom, we're finding some really unique ways to celebrate and remember those folks that we have lost and honor their memory, and to know that you're not alone. There is help, there's hope, and there's healing, and those are important. This Saturday, virtually across the country, we'll celebrate the International Survivors of Suicide Loss Day. Again, a virtual event hosted free of charge, and for anybody, anywhere they might be along their journey. Again, that message of hope, and that our grief journey is different for all, but there are resources available. And in particular for the veterans community, we partner with TAPS, the Tragedy Assistance Program for Survivors, which are tremendous when it comes to post-vention in particular and post-traumatic growth. I think between Adam and Dr. Farrow, you hit just about every community organization that I would hit. Some of the other places that we touched, I'll just mention them, and I will happily contribute some of my time to Brandy. The active duty and the National Guard and the reserves, we plug in with them regularly, and their family members, especially pre and post deployment for family members. We find a good connection with them. Law enforcement, health departments, school systems, local community behavioral health action teams or suicide prevention coalitions are tremendous advocates that we partner with. Chamber of Commerce, especially this time, we've been invited into different communities, different businesses to present And we find them to be, it can be Key Club, can be Rotary, whatever it might be. But it is absolutely a community effort, and that's the way we're approaching it. And I think we have a contribution there. And I would commend all of you to consider reaching out to your local AFSP chapter. They're probably reaching out to you or would like to help partner as we move forward. So again, in the interest of time, Brandy, I'll throw it back to you, but I'll look forward to the discussion and questions.
Thank you, Greg. All right, we'll go ahead and advance to the next slide. So I will round out our presentations, and you've heard a lot about the Mayor's and Governor's Challenge work. In a nutshell, it's a platform sponsored by Veterans Health Administration and the Substance Abuse and Mental Health Services Administration to give a platform to gather many of the community providers you've just heard about to do comprehensive suicide prevention, really taking that public health model that Adam talked about and others with the CDC. Next slide. And go ahead and advance to the next slide for time. So that you'll get the slides, and I can certainly talk offline with anyone about the structure of both our city level challenge and our capital city of Richmond here in Virginia, as well as that Governor's Challenge structure. I can talk about that with you offline, my emails in the slides. But I want to focus in on a pilot that we did because I think it ties a lot of the key points that our speakers have made up to this point, and what it actually looks like to bring all these players to the table and collect some data on their efforts. So we look at the Governor's Challenge priorities here, and it's identifying military service members, veterans, and families that are at risk of suicide through screening, promoting connectedness and improving care transitions, and increasing lethal means safety. So over about a year's process, as we worked through our technical assistance journey as a Governor's Challenge team, we developed a pilot that addresses all of those. Next slide. So the VISOR pilot, so Virginia's identify service members, veterans, and families, screen for suicide risk, and refer for services pilot. So you can see why we got that to VISOR, but it is still a brilliant acronym that our local, one of our suicide prevention coordinators at the VA created for us. Brilliant. But what we strive to do is to increase military culture, suicide prevention, and safety planning infrastructure in different community providers. So when we kicked off in December a year ago, we had about 40 agencies sign on, and they spanned local public mental health centers, a military clinic, community hospitals, social services, our health districts, and our State Department of Veterans Services. And we signed them on to work through the majority of this year. What we didn't know was that COVID was coming, right? And so you gather all of these partners, you have this amazing plan, and then insert global pandemic. So you have to keep things feasible and flexible. And I would argue that that's critical with community initiatives outside of a pandemic, but definitely in a pandemic. Next slide. Particularly when most of our partners were first responders in the COVID response. So I'm gonna dive into the data now, and because of the impact of COVID on agency operations for many of our partners, about half of the agencies were able to report, and I'm only gonna give you a snippet of the data from about February to April. This was our initial data collection, and it's like any data project with your initial, you're really striving for higher quality with the next poll and also lessons learned. So we'll dive in. Next slide. So when I look across those community sectors, they served over 2,000 SMVF. And of those, 64% of all of the individuals served were screened for suicide risk. And about a quarter of them screened at risk. So you may expect that in a hospital setting or a public mental health center, but you might not expect that in a local Department of Social Services or with our State Department of Veterans Services. But indeed, they were seeing individuals at risk. And had we not joined on with the VISOR pilot, they may have went unidentified. And so the data helps really put that in front of the partners and affirm their efforts to deploy screening. And I will say that most were using the Columbia Suicide Severity Rating Scale in their screening efforts. Next slide. So the reason I highlight this slide is we took that demographic breakdown of active duty, guard, reserve, dependent. Why I like this slide is because it showed the importance of asking about military connection through dependent or family member status, right? 600 of the 2,000 individuals were family members. And one of the areas in data collection as we were gearing up for the project is that partners weren't tracking dependent status. And as part of the pilot, they began doing that. And so again, being able to show this data back to our partners and say, this is why we ask this question. And even if they didn't screen for suicide risk, they have an understanding of the military connected individuals they're interacting with and can get them connected to VA, Department of Veterans Services, and other resources early before a crisis. Next slide. And this was neat when we put out of the total they served in these different sectors. So community behavioral health would be your public mental health centers and that military clinic. Social services or local departments of social services, state DVS, and hospitals, there are the sectors on the left. And of the total they served, what percentage were screened, what percentage of those screened at risk. And this gives them a measuring tool to work towards more comprehensive screening or universal screening. So all of our hospitals, as you can see, were universally screening, but some of our other partners, including community mental health centers, were not universally screening, and they used this data to make policy changes to increase the amount of screening they were doing for all Virginians to include SMVF. So we focused on the military and veteran lens, but it improved practices across their service populations. And something that Adam said stuck out with me with this is you want multiple organizations, multiple components, and multiple levels. And while that brief's amazing and is so true, it turns out when you're collecting data from all those sectors, it's a bit like the Wild West. So, you know, it's messy, beautiful. It's really important work, but it's tough. And it was tough pre-COVID, but then layer COVID on top of it. So for the Visor partner agencies that are out there, and for teams like Maryland, shout out, Maryland is looking at our pilot and trying to implement it. My heart goes out to you. This is incredible work, hard work, but a necessary tool, and the data helps to show why it helps. Next slide. And I'll just end with, we developed resource cards. This was early in the Mayor's and Governor's Challenge work, but that pocket resource, and this was designed for law enforcement, but has since been deployed in guard units, and other sectors. It's having that pocket resource. So when you engage with somebody that might be at risk or could just benefit from additional behavioral health and community resource connections, you know, we were training every provider that would listen that, you know, we need to get these cards out there, and we have it electronic in COVID days, of course, too. But so I flew through that, but I wanted to preserve time for questions for this great panel. And so with that, let's check out our Q&A function here. So Andrew asks, Dr. Farrow, can we talk about how to access VA and vet centers?
Okay, unmute myself. So the best way is probably going to be to go to va.gov and use the locator tool to find the facility that's closest to you. That way you can get information, contact information for that particular facility and be able to get connected to services. Now, there are some other ways. So for example, if you are to engage with the Veterans Crisis Line or go online with the Veterans Crisis Line actually does have information with regard to the suicide prevention coordinators and team for each facility as well. So it really depends on which avenue and what the need is. But just for general services, va.gov would be good. But if you're looking at, you know, needing some sort of crisis intervention, I think the suicide prevention team would be a great avenue to start.
Thank you. A quick reminder, you can drop new questions in the question and answer. We did have some submitted in advance, so I'll go ahead and pose one of those while we wait for additional questions to come in through the electronic function. So please talk about what people can do to recognize the signs of suicide and possible suicide risk and how to help if concerned. So Dr. Farrow, do you want to take that first, and then we'll let the panelists add in as they see fit?
Sure, absolutely. One thing that I would say is to just kind of look for signs like hopelessness or agitation, any sign, verbalizations or things that are said about not having reasons to live, or changes in their emotional states, substance use, withdrawal, things like that. But just kind of asking how they're doing, and being there, you're being around and spending time with veterans and families and friends. That's a way to start noticing those things. Taking gatekeeper training is another way to learn what some of the signs are. Once you notice the signs, it's really important to ask about them. Ask that question: are you thinking of suicide? Are you thinking of killing yourself? And then helping to engage them with the appropriate resources. So calling the Veterans Crisis Line, calling your local emergency resources, seeking help at your hospital's ER department, that sort of thing. But anytime we have a veteran or family member who is expressing thoughts of wanting to kill or hurt themselves, if they're looking for ways to die, talking about death and dying, or engaging in any kind of risky behaviors, we definitely want to make sure that we're asking about those things and ushering them into care. I think an important piece of that is really making sure that we're caring and supportive, and just allow them to talk about what's going on. We don't have to try to fix it or solve the problem, but just being really, open and non-judgmental, and, not feeling like you have to be a clinician. We're not asking lay people to do a risk assessment, but just being supportive and being caring can be very helpful in allowing them to tell you their story. And then you can say, hey, let's call the Veterans Crisis Line. Let's talk to someone who can get you some help.
I'd like to pile on. First of all, hey, Dr. Farrow, exactly. I think what you shouldn't do is dismiss it or hesitate to reach out. You should assume you're probably the only one that's going to reach out to that person. And then complimenting your non-judgmental. Too often, Marine Greg is different than social worker Greg. Marine Greg would say, suck it up. You got nothing, quit your bitching, do the opposite of what Marine Greg does, and listen, validate the feelings. Likewise, if you're the person struggling, I would encourage you to ask. That's difficult, but that's the right thing to do. That's the courageous thing to do. And I think too often, especially, I don't want to get sexist on you, but the males, oftentimes we don't ask for directions. We're not going to ask for help, but it's so important to ask for help. And I'm piling on. But something Brandy said on dependents, family members. I think oftentimes it's difficult to see among your family unit who might be struggling. And it's one thing to do with your clientele. It's another thing to do with your coworkers. It's another thing to do with your squadron mates or shipmates. Understand that every one of those deployments, every one of those moves, every one of those things affects that family. And you need to be aware along those same risk factors and warning signs that Dr. Farrow mentioned. So it's more than the one pile on, but I thought it was timely. Thanks.
Thank you, Greg. I think you did a great job. I love that analogy of the Marine Greg versus the clinician Greg. And that's why partnerships are so important, right? Because I always joke with our military service member and our human services partners is, over here in human services, the military service members and the veterans serving on our group help us ensure that what we're trying to do actually reaches the population, and they don't just block us out because we're not speaking the same language, we don't have the same culture and ways to connect. And then the service members learn ways to empathize and care and be better outreachers themselves. So that's the amazing part about partnerships. So another question. how can people without a military background help? And we've already started talking about this, but how can people without a military background help service members, veterans, and their families?
I'll throw one out there. If you're a clinician, if you're a practitioner, if you give, hey, psych armor, that's something 15 veterans want you to know. And it really is about cultural competence. And it's great. It takes you 5 minutes to go through the 15 things. What to say, importantly, what not to say. And it gives you some good insight in a very timely manner, succinct way on how to close that gap, which I think all of you are going to do anyway in your work. You want to be competent. I guess so that would be the one I would direct folks to, and I'd be happy to talk more about it if people want to know more.
So the resource, there we go. Adam, thank you. So Psych Armor, 15 things every veteran wants you to know. And while you're on Psych Armor, look around that video library. It is comprehensive and phenomenal. But Greg hit on it right there. One of the best ways to start, we always tell community providers, is to identify who you're already interacting with and serving that's military connected by asking about military, veteran, and dependent status. And then train in military cultural competency, and Psych Armor is a great way to start that journey. And there are lots of free and online products, as well as your VA partners can help with that too. So Greg, for you, if a non-veteran company wants to provide suicide prevention services in Maryland, where should they start?
A suicide prevention company that's got no military, is that what the question you said it, Brent?
Yes, so a non-veteran company wants to provide suicide prevention in Maryland. Where do they start?
They can reach out to AFSP, or that actually we have a Maryland Suicide Prevention and Intervention Network that's with the Maryland Health Department, Behavioral Health. There's any number, but AFSP, easy to touch. Our area director is available. You know, based on that discussion over the last hour, there's plenty of room for everybody to partner, and we can complement each other. So I would commend them probably to those two at a state level, also AFSP, and then your local health department typically has somebody that can connect you with or coalitions or organizations. I think that's close. That's what I would say off the top. Thank you,
Greg. All right, can my other panelists hear me? We're getting some comments in the, okay, thanks. Sorry, Maura, I'm sorry about that. All right, so with that, another immense thank you to our panelists and to all of you for tuning in. And I'm going to turn it back to Christy to close us out.
Thank you so much, Brandy and Sharonda, Greg, and Adam for being with us today. We were so appreciative of the content and the information that you all shared with us. I also just want to thank everybody that joined us all today. We hope the content was valuable for your time, allowed you further insight into some of the challenges our military and veterans may struggle with. As discussed today, we can all have an impact on prevention in our homes, neighborhoods, workplace, and communities, especially when it comes to lives of those who have served our nation. Remind that if you need assistance or further resources or connection in your community, we encourage you to reach out to your AmericaServes Coordination Center. This includes serving together in the National Capital Region, which are included on our website on the screen, Mission United of South Hampton Roads, PA Serves of Greater Pittsburgh, RI Serves in Rhode Island, and NYC Vets or Vet Connect NYC in New York City. And again, if you are having thoughts of harming yourself or others, we please encourage you to reach out to the National Suicide Prevention Line at 1-800-273-8255. And before we wrap up for today, we need your feedback. Please open your mobile phone and select your camera. Then hover over this QR code to be directed to a link to complete the feedback survey for this training. This will also allow you to provide us helpful topics you'd like to receive at future training events. For those that need CE credit hours, please continue to complete this survey, and instructions will be provided at the end of your survey on how to receive a copy of your certificate for attending today's training. We hope that you all will be staying safe and well, especially as we approach the Thanksgiving holiday. And we look forward to bringing you more training events like this very soon. And then we've also included the link to the SurveyMonkey if you need that as well. And we can also paste it into the chat for you guys if you have any trouble accessing the QR code. Now, again, I'll keep this on the screen for just a few minutes in case you're having any issues getting to that link. But thank you all again for attending today, and we hope you have a wonderful, wonderful day.